So I'm Natalie Cusano. It's an honor to be back at Columbia. Until very recently, I did my fellowship here and then was here for 5 years as junior faculty, and I just moved to Lenox Hill Hospital. This is a talk that was given as part of the Calcium Sensing Receptor Symposium at Endocrine Society. I used to give a talk on interesting cases of metabolic bone disease, but Dr. Bilazikian wanted me to switch to this one for this year's preceptorial. So today we're going to be talking about calcium signaling in hypoparathyroidism. So these are my disclosures. So today we'll review a little bit about hypoparathyroidism, which I know you've had some more extensive lectures on. And then we're going to be looking at the roles of the calcium sensing receptor and parathyroid hormone in maintaining mineral homeostasis, as well as looking at the familial hypocalcemic disorders of calcium sensing, so autosomal dominant hypocalcemia or ADH type 1, with and without symptoms of Bartter syndrome type 5, as well as ADH type 2. And then we're going to review what these familial disorders have taught us about calcium sensing in hypoparathyroidism and look at conventional and targeted therapy of ADH. So hypoparathyroidism, as you well know now, is a disease characterized by hypocalcemia and low or insufficient parathyroid hormone concentrations. And it's a rare disease. There are only approximately 77,000 patients with hypoparathyroidism in the United States. And it follows a so-called rule of 75% in terms of epidemiology. So 75% of cases are post-surgical, women, and 45 years or older. And it has been classified as an orphan disease by the United States and by the European Commission. So as we said, 75% of cases are post-surgical, 25% are medical. The most common medical cause being autoimmune disease, either isolated or as part of a complex syndrome. Today we're going to be focusing on some of the genetic causes of the disease. Again, this can also be either isolated or as part of a more complex syndrome. So PTH gene mutations and GCM2 gene mutations cause isolated hypoparathyroidism. Today we're going to be looking at mutations in the calcium sensing receptor and GNA11 that result in autosomal dominant hypocalcemia. So when low calcium is sensed through the calcium sensing receptors on the cell membranes of the parathyroid chief cells, there is production of PTH, which acts at the level of the bone to regulate calcium release from the skeleton, which is the largest reservoir of calcium in the body. And it acts at the level of the kidney to regulate reabsorption of calcium, magnesium, and phosphorus. And also at the level of the kidney to increase hydroxylation to 1-alpha or 1,25-dihydroxy vitamin D, which then acts at the level of the kidneys to increase absorption of calcium and phosphate. And through these mechanisms, we're usually able to maintain a normal range of calcium, magnesium, and phosphorus. And when there is an increase ambient calcium, there's obviously feedback of this mechanism. So when there's removal or damage of the parathyroid glands or abnormal activation of the calcium sensing receptor, these normal mechanisms aren't in place and there is subsequent impairment in mineral homeostasis. So this is what we think is going on in the parathyroid chief cells. So there's activation of the calcium sensing receptor by extracellular calcium. And this results in binding of the calcium sensing receptor to the G11 proteins. And this causes an intracellular signaling cascade that results in activation of phospholipase beta enzyme, production of inositol phosphate 3 and diacylglycerol, and an increase in intracellular calcium, which then leads to a decrease in the secretion of parathyroid hormone. So this is actually interesting because it's in contrast to the usual signaling pattern of intracellular calcium, where an increase in intracellular calcium usually leads to a stimulation of hormone production and secretion. So there's also another protein that's involved in this process. So adaptor protein complex 2, AP2 protein, facilitates the internalization of the calcium sensing receptor from the plasma membrane by endocytosis and retrograde trafficking. So this is a normal calcium sensitivity curve. So there's the set point here where there's 50% secretion of parathyroid hormone. You can see when there's hypocalcemia, there's maximum secretion of parathyroid hormone. And when there's hypercalcemia, there's suppression of parathyroid hormone. So I'm not sure if Dr. Bilezikian already brought up this point, but normal serum calcium varies widely across the population. So the normal range is anywhere between 8.6 to 10.2 or even 10.5 milligrams per deciliter. But within a given individual, there's a much more narrow range than that for the population. So even with excessive calcium intake, etc. Usually serum calcium is very well maintained within a certain level for a given individual. And so we can see that here. So it's interesting that polymorphisms of the calcium sensing receptor may underlie some of the variability in serum calcium in normal patients. So then here we're looking at a pathologic shift in the calcium sensing set point. So here the calcium set point is shifted to the right, and that's due to a decreased sensitivity to calcium. So higher concentrations of calcium are required to suppress PTH release. And this is what we see with familial hypocalciuric hypercalcemia, or FHH. And then here we see the opposite. So the calcium set point is shifted to the left due to an increased sensitivity to extracellular calcium. So PTH is not released at serum calcium concentrations that would normally trigger PTH release. And so these are the familial disorders of calcium sensing. So I think you all are familiar with familial hypocalciuric hypercalcemia type 1, or FHH type 1, which is due to heterozygous mutations of the calcium sensing receptor. And there's also two other forms of FHH due to mutations in GNA11 and AP2S1. Neonatal severe hyperparathyroidism is usually due to homozygous or compound heterozygous mutations of the calcium sensing receptor. So FHH typically presents incidentally with hypercalcemia that's noted on routine blood tests, and it usually does not have any complications of the disease. Neonatal severe hyperparathyroidism, on the other hand, as the name implies, presents very close to the time of delivery and does present with very symptomatic hypercalcemia. Today we're going to be focusing on these hypocalcemic disorders, so ADH type 1, again with and without features of Bartter syndrome type 5, and ADH2. So FHH1 and ADH1 are mirror image disorders. So they are due to inactivating or activating mutations of the calcium sensing receptor, respectively. And FHH2 and ADH2 are, again, mirror image disorders. They're due to inactivating and activating mutations of GNA11. What's interesting about FHH3 is that it's considered to be a more severe FHH variant with symptomatic hypercalcemia, low bone density, and cognitive dysfunction. But as of yet, there's been no gain of function mutations in AP2 causing ADH. So looking at autosomal dominant hypocalcemia type 1, again, calcium sensing receptor mutations. You can look it up on the online Mendelian Inheritance in Man website. That's its number. So the calcium sensing receptor is located on chromosome 3. And ADH1 accounts for over 70% of ADH. There have been over 90 different calcium sensing receptor mutations identified so far in patients with ADH1, and 95% are heterozygous missense mutations. So the classic features of the disease are typically mild to moderate hypocalcemia. So about half of patients will have mild or completely asymptomatic hypocalcemia. And on the other hand, the other half will have symptoms including carpopedal spasms, paresthesias, and in more severe cases, seizures. So if we compare patients with idiopathic hypoparathyroidism versus patients with ADH1, we'll see that the serum calcium tends to be much lower in patients with idiopathic hypoparathyroidism. There are two groups of patients with idiopathic disease on the left, and then two groups of patients with ADH1 on the right. So the patients with ADH1 tend to have serum calcium values that are greater than 6 milligrams per deciliter, while on the other hand, the other patients have much lower values. So patients here as well have inappropriately low but typically detectable PTH levels. They also tend to have hyperphosphatemia, And depending on where the mutation is in the calcium sensing receptor, they may have hypomagnesemia. And what's interesting, what really differentiates these patients with ADH1 from patients with idiopathic disease or other forms of hypoparathyroidism is that these patients have high or high normal urinary calcium excretion when they are not treated with calcium or calcitriol. So if we take a step back, so in the setting of low PTH, we would think decreased PTH action at the kidney would result in an increase in urinary calcium excretion because we know that PTH conserves calcium at the kidney. But in the absence of treatment, we typically see a decrease in urinary calcium excretion in hypoparathyroidism. And that's because the calcium sensing receptor independently affects calcium absorption. So in the setting of an intact and normal calcium sensing receptor response, decreased serum calcium is sensed independent of PTH, and the direct effects of the calcium sensing receptor on renal tubular absorption of calcium predominate over the effects of low PTH. So there's calcium conservation, typically, in patients who are not treated. So because of these patients having an inappropriate activation of the calcium sensing receptor, this leads to, when there's extracellular calcium, at any level of extracellular calcium, there's a much more pronounced hypercalciuria. And so we'll see this here as well. Again, looking at two groups of patients with idiopathic disease on the left, we'll see that their urine calcium excretion in the untreated state is very low. And actually only just a handful have urine calcium excretions that are at the low end of the normal range. They're typically just very, very low. The patients with ADH1 actually tend to have urine calcium excretion when they're not treated in the upper end of the normal range, or even that one patient has a frankly hypercalciuric value. So because of this, these patients are at very high risk for nephrocalcinosis, nephrolithiasis, and renal failure, and in particular during treatment with calcium and active vitamin D. We also see ectopic and basal ganglia calcifications in about a third of patients with ADH1. There have been a few kindreds that have also been reported to have short stature. So this is looking at a single family that was reported by Pierce and colleagues in the New England Journal in 1996. So there are 7 affected family members. They were genotyped and found to have a mutation, a substitution at position 128 of leucine for phenylalanine. And this is in the extracellular domain, the second peptide loop of the calcium sensing receptor. And you'll see that the curve for these patients is shifted to the left to wild type. So it's an activating mutation. So I'm looking at the spectrum of disease within this single family. So the affected members ranged in age from 6 months to 44 years. The serum calcium in general was above 6 milligrams per deciliter, but there was one family member with a lower value. When measured, PTH levels were low or inappropriately normal. Serum phosphate tended to be high, and in this family, serum magnesium tended to be low. And urine calcium excretion tended to be, again, at the upper end of the normal range, or even frankly hypercalciuric, and especially with treatment. Looking at these other features, you'll see that there was one patient who was completely asymptomatic. There was one that just presented with carpal pedal spasms. But you'll see that 5 of these family members had evidence of nephrocalcinosis or nephrolithiasis, and actually 4 had evidence of renal insufficiency. So looking at the calcium sensing receptor, again, it's found on chromosome 3. It's a 1078 amino acid class C G protein coupled receptor. It's got a large extracellular domain, a 7 transmembrane spanning domain, and an intracellular domain. And this is a figure taken from the McGill University website. They actually keep a record of all the reported calcium sensing receptor mutations, both activating and inactivating. And overall, there have been over 270 different germline mutations reported in the calcium sensing receptor. Oops. No, I thought there was another box there, but you can take a look at this website. It's interesting. It shows you exactly where the mutations are. So then looking at the mutations by disease association and location, so looking at FHH, neonatal severe hyperparathyroidism, and ADH. So the majority of the mutations are all in the extracellular domain. In ADH in particular, there's a slightly higher proportion potentially in the transmembrane domain and in the intracellular domain. And then looking at the types of mutations for ADH1, again, the vast majority, 95%, are missense mutations, with just a handful being reported as frame shift or in-frame deletions or insertions. Then looking a little bit more closely at this sequence and features of the calcium sensing receptor, we'll see the start and end of the venous flytrap domain. So it's an interesting domain. It's a characteristically distinct extracellular domain of the class C G protein coupled receptors, and it's responsible for ligand recognition and binding, and it's named for the venous flytrap because that's what it tends to look like. And so if we look at the hotspots in the calcium sensing receptor, so we'll see that there are a lot of mutations in the venous flytrap domain, both inactivating and activating. And the solid lines are those with a higher mutational frequency. We'll actually see that there are 3 amino acids here that cause both inactivating and activating mutations of the calcium sensing receptor. They're so-called shift amino acids. So if we take a look at this model of the calcium binding site in the venous flytrap domain, we'll see that 2 of those shift amino acids are predicted to extend across the entrance to the calcium sensing or the calcium binding site, and the other domain, the E297, is also intimately associated. So it's thought that these mutations may affect entry and binding of calcium within the venous flytrap cleft region, with opposing effects on calcium sensing receptor function. So then also there are some hotspots causing activating mutations in other parts of the domain of the receptor. So the second peptide loop of the extracellular domain and the transmembrane domain 6 and 7. So it's thought that the second peptide loop of the venous flytrap domain likely participates in the interface of the receptor, and mutations here may promote conformational changes such as dimer rotation facilitating receptor activation. And in the transmembrane domain 6 and 7, that region likely contributes to locking the ligand unbound receptor in an inactive conformation that inhibits the binding of G proteins, and so these mutations likely lock it in the opposite configuration. So I'm looking at ADH1 with features of Bartter syndrome type 5. So this is pretty rare. So only 6 mutations have been described so far causing this syndrome. So in these patients, they tend to be much more symptomatic than patients with just ADH. So hypocalcemic symptoms are reported in over 3/4 of patients here. And it's thought that activation of the calcium sensing receptor results in inhibition of the outer medullary luminal potassium channel, or the sodium chloride cotransporter, in these patients. So the mutations are causing these issues in the kidney. So Bartter syndrome is something that's described in the renal literature. There's a few different mutations causing Bartter syndrome, and so when this was described, it was called features of Bartter syndrome type 5. So what Bartter syndrome is it causes hypokalemic alkalosis, renal salt wasting, and hyperreninemic hyperaldosteronism. So if we look at wild type, just the black line, versus 2 mutations causing ADH without features of Bartter syndrome. For those mutations, you'll see again, the curve is shifted to the left. They're activating mutations. There's less of a response to extracellular calcium, but with the mutations that cause Bartter syndrome, there's a much more marked gain of function in these patients with features of Bartter syndrome. So then looking at ADH2, so this is, again, it's a separate disease, a different OMIM number. The chromosomal location of the GNAS gene is 19. And here as well, it's very rare so far. There have been only 6 missense mutations described in 31 individuals in the literature. So obviously fewer patients have been described, which limits observations, but as well, it seems to present with hypocalcemia that's typically mild to moderate, inappropriately low but detectable PTH concentrations, hyperphosphatemia. But in contrast to ADH1, these patients tend to have normal magnesium and tend to have normal urinary calcium excretion. So if we look at the families that have been described so far in the literature, we'll see that there's actually only been 1 patient so far that was described with hypercalciuria with ADH2, and that was during treatment with calcium and active vitamin D. The other cohorts that have been described in the literature have normal urine calcium and calcium that tends to be on the lower side, untreated. And then if we look at renal complications, so in the 2 families described by Mondstadt and colleagues, none of the 15 affected family members had any renal complications. In the family described by Lee and colleagues, there were 4 patients, only 1 had nephrocalcinosis that they described during an episode of vitamin D intoxication. And in the family described by Perret and colleagues, so that 1 patient that had hypercalcemia or hypercalciuria during treatment also had bilateral nephrolithiasis during treatment. And then the other family of 6 or 7 affected family members, none of them had nephrocalcinosis. So this is one of the cohorts, the one described by Lee and colleagues. So again, the one of the 4 patients, ages 9 to 42, had hypercalcemia and nephrocalcinosis during an episode of vitamin D intoxication. They compared their cohort of patients with ADH2 to a cohort of patients with ADH1. So this was 8 individuals from 5 unrelated families with a similar age distribution. But here, 4 of the 8 patients had a history of nephrolithiasis, and an additional 2 patients had a history of nephrocalcinosis. They compared the fractional excretion of calcium between these 2 cohorts, and you'll see that the patients with ADH1 had an over 2-fold higher urinary calcium excretion than the patients with ADH2. So it brings up the question of whether the calcium sensing receptor in the renal tubule couples to a G protein other than G11. So obviously this requires much more study, but things that are of interest that are coming up in a clinical setting and that we can then go and apply and do more basic science research on. So as well, short stature has been reported in 2 of these kindreds, and because there's just so much less data, it might be that this is a more significant finding in ADH2 than it is with ADH1. So then looking at autoimmune causes of hypoparathyroidism. So, so in terms of the disorders of calcium sensing, so again, the loss of function and the gain of function, there can be calcium sensing receptor antibodies that cause inactivation or activation of the receptor. So there are definitely inactivating mutations described causing an FHH-like picture. We're going to focus on the ones that are activating. So anti-calcium sensing receptor antibodies have been noted in patients with autoimmune polyendocrine syndrome type 1 or APS type 1. And APS type 1 is due to mutations in the autoimmune regulator or AIR gene, which appears to be a nuclear transcription factor and is expressed in various organs. So does anyone know what the classic triad of the disease is?
Candidiasis. Candidiasis.
Mm-hmm.
The hypophagia.
Yep, there we go. Yep. So yeah. So hypoparathyroidism is typically the presenting symptom of these patients. And we also see mucocutaneous candidiasis and adrenal insufficiency, as you said. So excellent. And so in a series of patients with APS1 or hypoparathyroidism in the setting of other autoimmunity, depends on what series, but 20 to close to 86% of patients had serum that was positive for anti-calcium sensing receptor antibodies. And these antibodies were directed against the extracellular domain of the calcium sensing receptor. And in 2 studies, they were found to activate the receptor in vitro. They don't appear to be cytotoxic. So there were 2 patients described who had, one with resolution of the disease. So he presented with adrenal insufficiency and also hypoparathyroidism. He was treated with high-dose steroids and subsequent physiologic hydrocortisone, and his hypoparathyroidism actually remitted after 3 months. And then another patient had Graves' disease and hypoparathyroidism that was diagnosed at age 14. Over 10 years later, he had thyroid surgery and was noted to have a histologically normal parathyroid gland. So then looking at conventional and targeted therapy. So as we said, these patients are at very high risk for renal complications. So unlike other forms of hypoparathyroidism where we would treat even if they're asymptomatic to get their calcium levels to goal 8 to 9 milligrams per deciliter, in these patients we really want to avoid treatment if they're asymptomatic. And in symptomatic patients, you really want to titrate therapy to the lowest doses of calcium and active vitamin D that will alleviate symptoms. So here is another forms of hypoparathyroidism. Thiazide diuretics may be helpful to reduce hypercalciuria. In one case series of 2 young patients with ADH1, hydrochlorothiazide did significantly reduce urine calcium excretion. But there was another patient described with a frame shift and truncation of the calcium sensing receptor, and here hydrochlorothiazide did not significantly alter urine calcium. So it may seem that it depends on exactly where the mutation may be. Then looking at PTH therapy, unfortunately, trials of rhPTH1-84 and hypoparathyroidism excluded patients with known calcium sensing receptor mutations. So we don't have data on these patients with rhPTH1-84. There is some limited data using PTH1-34 in these patients. So there was a 28-week crossover study of PTH1-34 sub-Q twice daily versus calcitriol. Apologize. This was in 17 adult patients, including 5 with ADH1. And PTH1-34 increased serum calcium in patients with ADH, similar to patients with other forms of hypoparathyroidism, but it didn't increase or decrease urinary calcium. And then in a longer-term study, including 6 adult patients with ADH1, and there were 4 in the treatment group, PTH did decrease urinary calcium excretion in the group as a whole, but patients with ADH1 were not analyzed separately. And then looking at a crossover study of PTH1-34 by continuous pump delivery versus sub-Q in 12 children, including 7 with ADH1, serum calcium was increased in both PTH1-34 arms, so both with sub-Q or continuous pump delivery, but neither form of delivery really had any effect on urinary calcium excretion in patients with ADH. Well, this is the longest term data that we have using PTH therapy in the disease. So this is a case report of a 20-year-old woman with a heterozygous calcium sensing receptor mutation causing ADH1, and she'd been treated since 6 years of age with PTH1-34. There was improvement in her serum calcium with an improvement in her self-reported symptoms of hypocalcemia. And there was a decrease in hypercalcemic episodes compared to prior therapy with calcium and calcitriol. So obviously all these are important in terms of the patient's quality of life and health care. But unfortunately, the increased urine calcium and magnesium excretion persisted despite keeping her serum calcium magnesium at goal normal to low normal. And she did have nephrocalcinosis without renal impairment that happened at age 19. So I'm looking at targeted treatment. So You're probably aware of calcimimetics that we use for inactivating mutations of ADH. Well, calcimimetics we use for secondary forms of hyperparathyroidism or for primary hyperparathyroidism that is going to be medically managed. So Cinacalcet is a type 2 calcimimetic. It's a positive allosteric calcium sensing receptor modulator that increases activation of the receptor. And it's approved for use in the treatment of parathyroid carcinoma and primary hyperparathyroidism for patients unable to undergo parathyroidectomy or secondary hyperparathyroidism in patients with CKD on dialysis. It also has been used in patients with symptomatic FHH1, 2, and 3, and as a temporizing measure in neonatal severe hyperparathyroidism with lowering of serum calcium in most mutations that have been studied. So we're going to be looking at the calcilytics. So calcilytics are negative allosteric calcium sensing receptor modulators that inhibit activation of the receptor. And you may have heard of these treatments as a potential therapy for osteoporosis. So that was their initial intent. So they were to be used as an oral therapy to endogenously increase PTH concentration so that patients would not have to do sub-Q injections of parathyroid hormone. Unfortunately, they were not found to be efficacious in osteoporosis, but they still may be helpful for the treatment of ADH. So obviously, most therapeutics have been designed to target normally functioning wild-type receptors or enzymes, so they need to be further studied in patients with mutated receptors. So these are the calcilytic compounds that have been developed. So there are two classes, the amino alcohols and the quinazolinones. So ranocaluret was the drug that had been in phase 2 trials for osteoporosis, so that was in the amino alcohol class. So what is interesting is that Cinacalcet and calcilytic MPS 2143 are predicted to bind to similar regions within the calcium sensing receptor transmembrane domain cavity. And so these at the top are homology models of the receptor transmembrane domain based on a different receptor in the class. And so Cinacalcet binding is in purple and MPS 2143 in blue. And you'll see that they're binding to very similar areas of the receptor. So again, calcimimetics act by stabilizing the transmembrane domain in a conformation that facilitates the coupling of the G protein, while the calcilytics probably stabilize the transmembrane domain in an inactive conformation to help with the issue of excess activation. So looking at in vitro studies in ADH1 and 2, so various of these calcilytics have been shown to normalize various mutant calcium sensing receptor signaling responses indistinguishable from wild type. So that's very promising. Unfortunately, MPS 2143 was only partially effective in the response in 4 severe mutations causing Bartter syndrome type 5. But for these mutations, 2 of the other calcilytics were able to significantly mitigate the excessive cytosolic calcium signaling that we see. So functional in vitro tests with calcilytics have been reported for 32 activating calcium sensing receptor mutations and 2 activating GNA11 point mutants, with all sensitive to at least one of the calcilytics in vitro. So that's great news. In terms of in vivo studies, so a few have also been studied in mouse models. So there are 2 knock-in mouse models of ADH1 and another mouse model generated by random mutagenesis. And all these mouse models replicate the human phenotype with decreased serum calcium, normal to low PTH, increased serum phosphate. And the 2 knock-in mouse models also have relative or absolute hypercalciuria like we see in patients with ADH1. The calcilytics that were studied, MPS 2143 and JTT 305, did all show an increase in serum calcium and PTH while also stabilizing or decreasing urine calcium excretion in all 3 mouse models. So that's great. Looking a little bit more closely at the JTT 305 study, which was a longer term study over 3 months. So here in the left set of bars are the mice that were control mice. So their urine calcium excretion on the axis is relatively low. The middle is one of the mutations, and on the right is the other mutation. So in pink are the bars of the PTH treated mice. So you'll see that those bars are similar to the mice treated with vehicle. So PTH did not seem to decrease urine calcium excretion in these mice. But the blue, JTT305, administered for 3 months in both mouse models, did decrease urine calcium excretion compared to both vehicle and PTH 1 to 34. And then looking here, these are renal biopsies of the mice. So at the top is our vehicle-treated mice, middle JTT, and the bottom PTH. This is not working so well. So the PTH-treated mice did have renal calcifications, as did the mice treated with vehicle, but the mice treated with JTT305, this was able to prevent the renal calcification by this staining compared to both vehicle and PTH 1 to 34. I apologize, I made my slides on a Mac, so I think there are a few Mac to PC issues here. So then looking at patients with ADH1, there's only been one very small study. So, actually, sorry, this is looking at normal calcemic patients. So looking at patients with normal serum calcium and therefore presumed wild type calcium sensing receptor present, these calcilytics have been studied in over 1,000 healthy individuals in phase 1 and phase 2 clinical trials. And so here, 8 out of the 9 studies reported a dose-dependent increase in serum calcium in healthy patients. And serum calcium returned to pre-dose levels about 12 hours after a single dose. And with prolonged use of 2 weeks or longer, serum calcium did still increase and decrease acutely, but they remained above pre-treatment levels with a gradual increase. The PTH levels increased rapidly with a return to baseline after 6 to 12 hours with both acute and chronic use. Unfortunately, the PTH curve that we see with PTH 1 to 34, for example, there's a much shorter time when PTH is there. So here, even though it says it increases rapidly with a return to baseline after 6 to 12 hours, PTH levels still were elevated for a longer period of time, and so that's why it doesn't seem to act as well as an osteoanabolic therapy in healthy or osteopenic patients. As well, there were 3 trials that compared the calcilytic to PTH 1 to 34, and so here ronicalcium and AXT914 were more effective in increasing serum calcium with a greater cumulative increase in serum PTH concentration. So unlike in osteoporosis and patients with ADH, we'd actually want more calcium and PTH response. And so it seems as if these medicines are better used for therapy here. So in one study that looked at urine calcium excretion in patients given ronicalcium versus PTH 1 to 34, both of them decreased urine calcium through 12 hours after administration. But even at the lower dose, ronicalcium was more effective in lowering urine calcium than PTH. And at the highest dose, ronicalcium dropped the fractional excretion of calcium by close to 90%. Urine calcium returned to baseline about 12 to 24 hours after administration for both arms. So if we look at chronic administration once a day for several weeks, both serum and urine calcium excretion increases. So it's thought that raising the serum calcium leads to a greater calcium load, which increases urinary calcium excretion after the acute effects of ronicalcium or PTH have worn off. So if we are to use these medicines for patients with ADH, we'd want long-acting calcilytics, sustained release forms, or multiple daily dosing in order to reduce hypercalciuria. And adverse events in general were pretty mild. They included headache, and there were events that were thought to be dose-related, including nausea, diarrhea, and arthralgias. So in here, this is the study looking at patients with ADH1. So NPSP 795 was studied in 5 patients with activating calcium sensing receptor mutations causing ADH1. And here, treatment with calcium and calcitriol was discontinued prior to the study. And after an overnight fast, the patients received escalating doses by IV infusion. So PTH levels increased, the fractional excretion of calcium decreased in a dose-dependent manner, but serum calcium actually remained stable without patients getting additional supplements, but it did not increase. So it may be that we just didn't reach the right dose of of the calcilytic in these patients, or that maybe this calcilytic isn't the best one for patients with ADH. So obviously there's a number of questions that we need to be answered in the future. So the delineation of the exact structure of the calcium sensing receptor and intracellular signaling cascades in the parathyroid chief cells, the kidney, and other targets. What are the appropriate serum and urine calcium targets for patients with ADH1 and ADH2? Will calcilytics decrease the renal salt wasting in patients who have the features of Bartter syndrome type 5? And will calcilytics decrease hypercalciuria long term, leading to a decrease in renal complications in these patients? So in summary, ADH1 and ADH2 were due to mutations in the calcium sensing receptor and GNA11 genes protein, respectively, and they typically present with mild to moderate hypocalcemia, low or inappropriately normal PTH levels, and hyperphosphatemia. The identification and characterization of mutations in these proteins have led to a better understanding of the parathyroid and renal G protein coupled calcium sensing mechanisms. Renal complications are increased in patients with ADH1, in particular during therapy with calcium and calcitriol, and calcilytics show promise in treatment of patients with symptomatic ADH. There's actually a trial ongoing right now, or about to start at the NIH. So you may be learning about this soon, or you might be able to tell me more about it. Okay, I'd like to thank you for your attention and take any questions. So yeah, so obviously the other forms of hypoparathyroidism are much more common, but something to look for in patients who don't have a history of surgery. You might want to check their urine calcium excretion right away and see if you think they might have one of these mutations, because if that's the case, the treatment does vary. You wouldn't want to treat them with high doses of calcium and calcitriol if that were the case.
What will be your calcium goal?
Yeah, again, it's very individualized here. So yeah, it really depends. Just the lowest amount that you can give where patients aren't symptomatic, and you want to check their urine calcium very closely. But yeah, as with other forms of hypoparathyroidism, again, we have a goal serum calcium of 8 to 9 milligrams per deciliter. And that's for a number of reasons. So patients might be symptomatic or more often symptomatic if their serum calcium is lower, but also if they become sick. We know patients with hypoparathyroidism can have acute drops in their serum calcium. So if they're kept within 8 to 9, then hopefully if they have a drop, they're still within the 7s, and you might not need to bring them to the ED for IV calcium. Because if they're starting in the 7s and drop to the 6s, then that's different. So again, it's going to be really individualized for patients with this disease based on how often they become symptomatic and what their urine calcium is.
I have a question. You mentioned that these patients can have high normal urinary calcium excretion when they are not treated, but there is an overlap between FHH and primary hyperpara with the fractional excretion of calcium around 1.4. So do you have a threshold for these patients?
Again, yeah, there's no set threshold in terms of what you would think, but again, as you saw, so patients with other forms of hypopara, if they're not treated, then their urine calcium excretion is either very, very low or just at the lower end of the normal range. So if the urine calcium's at the higher end of the normal range, then that would make you think about this.
But there is no threshold that you say, like, you know, like any...
Right, exactly. No, there's a lot more patients with FHH than with ADH.
I have a curiosity. I know that maybe there are 100 patients studied. Anyone look into the cardiac function in this hypoparathyroidism patient? I mean, they don't have symptoms of hypoparathyroidism. Everyone look at from the QT. They have longer QT. Because I mean, we don't treat it, but
right.
I don't know how to treat the patient without symptom, maybe a prolonged QT.
Yeah, there's not a lot of data that I know of in these patients. I actually don't know of any data with regards to that. Yeah, obviously we worry about a prolonged QT because it's more associated with torsade de pointes. But thankfully, hypocalcemia is less associated with arrhythmias like that than are other causes of other electrolyte causes of the issue. So.
I have another question. So once we start like suspecting ADH and we want to test for any of these mutations, do you send whole exome sequencing, or what type of test do you send?
Yeah, so it's up to what's available to you. So Quest actually has a calcium sensing receptor mutation gene analysis. But if you have access to a genetics division, then you might want to send them there and have more extensive analysis done, because there is some overlap, so you might want to check for PTH or GCM2 gene mutations as well, or other mutations.
So you mentioned getting a 24-hour urine, like even just in post-surgical patients, just to see if maybe they have this. Even so you're saying like even before you begin treatment and somebody who you suspect has post-surgical.
Not for post-surgical, because then you have the cause. But yeah, so urine calcium excretion is not done enough in patients with hypoparathyroidism. I'm sure that was discussed with you already, because it is very helpful. So patients with hypopara in general are prone to get these renal complications with treatment. And so it's definitely something that we want to be monitoring more in our patients. And I know we get some pushback from patients sometimes because it is a little bit of a pain to do. But I think if we tell them that it's to help prevent the risk of renal complications going forward, that they might be more likely to do it. Because there are ways that we can intervene, obviously. So we can try and change their ratio of calcium or calcitriol. We can try RHPTH1 to 84. We could try a thiazide diuretic. So there are things we can do to lower urine calcium, and just it's not getting picked up on a lot of patients before the fact happens.